Your attention. So my name is Greg Ball. I'm the Dean of the College of Behavioral and Social Sciences here at the University of Maryland College Park, and I'm delighted to welcome you to this year's Global Health and Culture Lecture Series. This is a joint series sponsored by the School of Public Health and the School of Behavioral and Social Sciences Department of Anthropology. And I want to thank Thurga Sangaramurthy and Liz Mari here, one from BSOS and one from Public Health, for the great work they've done in initiating this series, which is something very appropriate. I'm very pleased to introduce this year's speaker and event. You know, when we think of health in our culture and in several other cultures as well, we just immediately go to the technical sides of medicine. Oh, there's this new device that's a pacemaker, or they have this new visualization for surgery, or there's a drug. We think about these as the advances in health. But it's almost a cliche that we all know that the way to make the biggest difference in health is applying things that we already know are important. And some of the obvious things in our culture is there's now a very good cultural consensus to help people stop smoking, and that has had obvious improvements in people's health and clean water and these kinds of things. Not that that's trivial to do, but we know it's important. But applying knowledge and things to try to make healthcare work better gets very complicated very quickly. And it especially gets complicated when you start to involve cultural preconceptions, legal preconceptions, and how these interact with the ability to provide care. And our speaker today, Brian Honermann, is an attorney who's been working in this space for many years. He's now at the amfAR, which is the Foundation for AIDS Research, where AIDS especially is an example of a disease which from its initial discovery was fraught with challenges because of myths about what it caused. I was living in New York City when the AIDS epidemic broke, and I remember listening to all kinds of different myths about what happened and whether you can't touch someone who had AIDS because you would get it, and people panicking and all sorts of roiling emotions. And although we've made great advantages in managing AIDS, we still aren't where we want to be and taken care of, and Brian's going to talk to us about that today. Brian has a very interesting background that brought him to this. He did his undergraduate degree at University of Wisconsin-Madison in English and creative writing. His law degree is from Fordham in New York City, and he's been at amfAR for 4 years, and very much look forward to his presentation being useful and not a part of the problem. Brian, thank you for coming to the University of Maryland.
Thank you, and thank you all for being here. My background is in law, and that's how I sort of have come to this movement around HIV. After law school, I spent several years living in South Africa, working with organizations on the ground there, named the Treatment Action Campaign, then subsequently with an organization called the AIDS Law Project. And so that's what really informed a lot of the way that I conceptualize how work in this area should really be done. And so I want to talk a bit about where we are in the HIV epidemic today, and what that means in terms, and the battles that we won, and what that means for how we think about the fight for global health going forward, and how I think about being useful in sort of this space of global health. I'm going to do that first by going a little bit over where we are in the epidemic today. So globally, there are about 36.9 million people living with HIV around the world, the vast majority of those in sub-Saharan Africa. In South Africa alone, there are 7.2 million estimated people to be living with HIV. That's in a country of about 55 to 60 million people total. And this has been the case for some time. And this shows the number of new infections that are happening every year, and the regionalization of the number of new infections that are happening every year, and how this has really developed over the past 20 or 30 years. And so what you see here is we've done a very good job of reducing the number of new infections that are happening, but there's still about 1.8 million new infections that are happening each year. And you see in the yellow line there, that is the infections that are happening in East and Southern Africa, and then the next line down is those that are happening in West and Central Africa. The only region in the world where you're actually seeing increases in the rate of new infections right now is in Eastern Europe and Central Asia, largely fueled by injection drug use. And the importance of this is, while we've done a very good job, we're not really down at a point where we really need to be. And we need to bend this curve significantly further and reduce the number of new infections that are happening. And along the way, in terms of the fights that we've won and why we've managed to increase the number of new infections, I think there are some obvious examples, and I think they tell us a little bit about where we have to go in the future in a fight that's much more complicated. So first, we won on drug pricing. These are data from MSF, and they show what antiretroviral drug costs were in the early 2000s globally and what was available, right? And so what you see over there in the black bars is what the price was out of brand name pharmaceutical companies. And what happened when the generic companies in red there introduced product to market. And that was really done by Cipla out of India and other Indian generic manufacturers. And they did it because at the time the World Trade Organization's intellectual property requirements were not in place in India. And they were not in place in a lot of sub-Saharan Africa, as they're starting to go into place today. And it makes the fight a little bit more complicated. But we won this, and what really confirms that we won it is this organization called the Medicines Patent Pool. And this was founded in 2010 by Unitape. And what the Medicines Patent Pool does is it makes agreements with pharmaceutical companies, brand name pharmaceutical companies, over their patented medications. And it reaches agreements that are mostly royalty-free to make generic manufacturing available to the countries that you see in blue there. Right? All of those are able to access all of these antiretroviral medications on the generic market. And they're able to do it at prices way below what brand name manufacturers would be able to deliver, even if they were delivering it at cost. And this has really led to, because of the revolution in intellectual property laws and how we've really looked at it, it's led to sort of this point that happened in 2017 and now in 2018, where we're flipping the script around what's available in developing countries versus what's available in developed countries. This is a product that's being introduced now called TLV, that is the result of an agreement between the Clinton Health Access Initiative, amfAR, the US President's Emergency Plan for AIDS Relief, Mylan Pharmaceuticals, Aurobindo Pharmaceuticals, the Kenyan government, and the South African government in particular. And what they've done is they've agreed to introduce this product, TLV, which is the combination of a product called tenofovir, lamivudine, and dolutegravir. And they've agreed to introduce it at a cap of $75 per patient per year, a cap. So it's actually seeming like it's coming in under that price. We're getting it at about $60 to $65 per person per year. That's what we're paying overseas. And what's interesting about this particular product is when I talk to clinicians, they say if you have every antiretroviral available to you, the 3 that you would want to be on, people probably know, for HIV treatment, you need to be on at least 3 different kinds of medications in order to be sustainable, right? The 3 that you would want to be on are really these 3 drugs. Tenofovir, which was originally patented by Gilead, went off patent in the United States last year. Lamivudine, which was originally patented by GlaxoSmithKline, went off the patent a couple of years ago. And dolutegravir, which is patented by ViiV, and it remains under patent. These 3 drugs are really the epitome of what you would want to be on. But because they're patented by different companies, they're not able to be combined into a single pill here in the United States. They are available in a single pill that's taken once a day in other countries. And so we've really flipped the script to the point where modern HIV treatment is really available in developing countries before it's being made available in developed countries. That's the moral argument that we've won, and the argument we've won around antiretroviral drugs. We have not won this, I would like to say, for cancer. We have not won it for a number of other diseases, but we have, in many ways, won it for HIV. What else have we won? We won global financing mechanisms. In 2002, the founding of the Global Fund was established. The Global Fund to Fight AIDS, Tuberculosis, and Malaria. That was followed very quickly by the US President's Emergency Plan for AIDS Relief, which was founded by George Bush in 2003. Both of these programs work very collaboratively and together And both of them have distributed about $46 billion each in funding since their creation. These are disbursements that we see from donor governments going out into countries. And these are disbursements, so we're actually looking at how much money each year went out. Right? And you see the dramatic increase from 2002 until about 2008 or 2009 when the global economic crisis kicked in. And we see this leveling of how much money was really going out. And I have to point out, these are data from Kaiser, and what Kaiser says is this increase that we're seeing here in 2017 is actually probably a little bit artificial. It exists because of funding that was made available in the earlier years in 2015 and 2016 that was subsequently actually spent in 2017. So there's actually less increase that we don't expect this trend to continue. And this talks a little bit about that. So these are data that PEPFAR likes to show, which looks at how much money we've been allocating for global HIV programs through PEPFAR and how many people are on treatment. So the blue bars there show how many people are accessing antiretroviral treatment with support from PEPFAR. Not 100% support from PEPFAR, but with at least some support from PEPFAR. And you see from about 2009, when we had about 2.5 million people on treatment in all of the PEPFAR countries, to 2017, we now have 13.3 million people on treatment with support from PEPFAR. And we're doing it with the same budget. And we're doing it with the same budget because of two things. One, we had accumulated relatively large bank accounts because the funding that had been made available in some of these earlier years of the PEPFAR program was not flowing out as quickly as it needed to be. And so that built up in bank accounts, and we spent it down in this period in the pink here. Since then, we've sort of exhausted that account, and now we've been expanding largely in this gray or in this green area through improving efficiencies. We've made decisions about only investing in particular places that have particular epidemics that we can have the greatest impact for the smallest amount of money. But that's not necessarily the right way to fight an epidemic overall. And we're coming to the end of what efficiencies we're going to be able to gather. There aren't further drug cost reductions coming. There aren't further efficiencies that are going to be pulled out of this system without being very careful about what happens in the interim. What else did we run? We won enormous amounts of HIV research. So these are all the drugs that have been introduced into the market since the beginning of the epidemic in 1981, when we identified the epidemic. And I'm not going to go over the history of this. If you want to know more about the history of this, there are many good documentaries out there. There are very good books out there to go and read. I recommend you go and look at those. But what I want to point out is we've gone from this period back in 1996 when modern antiretroviral treatment really became available and was incredibly complicated and involved taking many, many pills multiple times a day, to where we are today, which is HIV treatment is one pill once a day. That's it, and you'll be fine. The life expectancy of people living with HIV today is the equivalent of people who are not HIV infected, because the drugs have gotten that good. And that's the result of HIV research. And NIH research is continuing to get funding. We still get about $3 billion per year in NIH HIV-directed research. You can see in the red here that that's declining in terms of the purchasing power because inflation eats away at flat budgets. But it is still a significant investment, and that's an investment that's going into HIV cure research, that's an investment that's going into HIV vaccine research, it's going into work around still new drugs, it's going into work around also complications of people with HIV aging. We are starting to come up into a lot of new information about the complications of people aging with HIV. But this is where we are, right? So this orange bar that you see at the bottom here is where UNAIDS projects we need to get in terms of new infections before we start to get ahead of the epidemic. Right now, we are still way above that, particularly in East and Southern Africa, right? And the question is, how do we bend this curve? How do we bend it down until we get it below this orange line? And the urgency around this isn't just new infections. The strategy has come from UNAIDS. And the strategy is this 90-90-90 strategy that has been developed. And what the 90-90-90 strategy says is 90% of people living with HIV should know that they are HIV positive. They should be diagnosed and know they're HIV positive. Of those, 90% should be on HIV treatment, and of those, 90% should be virally suppressed. And the theory behind this, this policy and this strategy is that people who are HIV positive and are on successful treatment and are virally suppressed are not infectious. They are no longer infectious to their partners. And that's incredibly important because it means our treatment is a prevention intervention as well. It's also incredibly destigmatizing to know that as an HIV positive person, you are not actually infectious if you're controlling your own epidemic, if you're controlling your own disease and you're remaining true to your drugs and remaining on drugs. But where we are today, there's 36.9 million people living with HIV, only about 59% are on treatment. 41% of the HIV positive population that is missing from treatment. Those who are on treatment are doing quite well. Yeah, the viral suppression rates are around 80 to 85%. But the problem comes in is this. These are data that amfAR likes to show regularly. There's a changing demographics that's coming. So these are data looking at the population pyramids. This is an example from South Africa. 10 to 29-year-olds back, if you look back at 1995, there were about 7 million 10 to 30-year-olds, right? 10 to 30-year-olds are the most likely population to become HIV infected. And so those are the population we really need to get at. And that population, by 2015, has grown to over 10 million. There are more children being born. Children are surviving better because we've got better health care. And they're just greater populations. And what that means is, even though we've reduced the number of people becoming infected, the rate of new infections by more than 50%, there are more people eligible to become infected. And that creates huge concerns for how do we get ahead of an epidemic where more and more people are eligible to become infected. And this goes to that question as well. This shows how many people, or the percentage of people that are virally suppressed by age group. These are data from Eswatini, formerly known as Swaziland, that amfAR has been doing through these population health index assessments, or FIAs. And what you see here, the 15 to 24-year-olds are the least likely to be on treatment, to be on successful treatment. The 25 to 34-year-olds are a bit better. And the light green is women, the dark green is men, right? So men are way behind on this. And they're way behind because they don't get recruited into healthcare services. Women get access to healthcare services and through the integration of HIV with sexual and reproductive health services, including contraception, including antenatal care, all of those services that women go and get access to, that young men in particular don't bother to get access to. And what this means, when we have very few people on treatment, or relatively few people on treatment in these age groups, is this problem where the HIV infection cycle is taking place before we ever get people on treatment. So if the 90-90-90 strategy is built around the idea that having people on treatment and having them virally suppressed will reduce new infections, you have to do it in young people. Otherwise, you don't intervene in this infection rate. The last point on where we are with the current epidemic is that there are still 1 million people dying every year with HIV. That's 1 million people who are dying with specifically AIDS-related causes because they're not getting access to treatment. There are people dying of all sorts of other things with HIV. There are 2 million people every year who die of tuberculosis, but there are 1 million people dying every year because of lack of access to treatment. So what does this mean for the fight going forward? And I think, I want to do this through sort of this question of what does advocacy look like when the people you're targeting for advocacy agree with you, but they don't necessarily know how to do better, right? That's the policy intervention that we're really looking at. We've won a lot of these hard, but what I call obvious fights, right? When we look at the global HIV epidemic, it was obvious in 2000 that the problem was drug pricing. It was obvious in 2000 that the problem was lack of access to treatment. it was obvious that we needed to solve the financing problem. Those problems aren't the same problems anymore, and they're much more complicated problems going forward. The prevention tools that we have aren't enough. Treatment as prevention will not get us to ahead of this epidemic. Even things like pre-exposure prophylaxis, which is HIV negative people taking drugs to remain negative, aren't going to get us. Even combined with treatment as prevention aren't going to get us there. Condoms are already built into this. Prevention of mother-to-child transmission programs are already built into this. And we are not ahead of the epidemic, and we are not getting ahead of the epidemic. And how do you deal with it when the data that people are using to make decisions are, everybody agrees and understands are wrong? When we talk to people about key populations programs in particular, programs that are targeting men who have sex with men, programs that are targeting sex workers, everybody knows that the data on those populations, on how we deal with people who inject drugs, we all know the data on those populations are very, very wrong. But we have to make decisions anyways. And the challenge is how do you get people to make the right decisions with the right resources in the absence of good data, when so much of our decision making is built around the idea that data will answer our questions. And then this last point about the resources that are available are pushing us towards greater efficiency, right? We are restricting the resources because there's no more money coming, and that pushes us towards greater efficiency, but a lot of that interferes with what makes health systems work in the first place, and we have to guard against that. I want to talk about this through sort of an example of two different cases in South Africa. So there's two things to, I think, understand about South Africa, to understand this whole, why I'm tying this together. The first is South Africa has a very progressive constitution. This is from the final constitution, which was passed in 1996, post-apartheid. And this is section 27 of the Constitution, which guarantees the right of access to healthcare services, including reproductive healthcare, the right to access to sufficient food and water, as well as Social Security and some other things, right? And that the government has to take reasonable legislative and other measures within its available resources to achieve progressive realization of these rights. And that nobody may be denied emergency medical treatment, that's not part of this. The other point that you have to understand about South Africa, for those who don't know, is that between 1999, around 1999, when Thabo Mbeki came to power, and 2008, when Thabo Mbeki was thrown out of power, the African National Congress, or the ANC, the party of Nelson Mandela, that became the party of Thabo Mbeki, and is still the ruling party in South Africa, adopted an AIDS denialist approach. And why that is, between Thabo Mbeki as president of the country and the health minister, Manzu Tshabalala, either they believed HIV did not cause AIDS, that was something that came out of Thabo Mbeki's speeches, or that the treatment for HIV was more toxic than HIV itself. Right? Both of those are AIDS denialist positions, and they're both wrong. But they are the background of what I'm going to talk about here. So the first case I want to talk about, this is looking at a very famous case called the Minister of Health versus the Treatment Action Campaign, number 2. Number 1 was just preliminary injunctions sort of stuff. But number 2 was the actual merits of the case. And what it did was challenge the South African government over its policy not to make PMTCT available. So prevention of mother-to-child transmission, for those who don't know, HIV-positive women who become pregnant without treatment, without any intervention, pass on HIV during labor in about 30% of cases to their babies. Babies who are infected with HIV without treatment, and I will say treatment for pediatrics even today is incredibly complex and incredibly difficult, and the outcomes are not always great. Without treatment, infants, 50% will die by the age of 2, 75% will die by the age of 5. Right? So not having access to prevention of mother-child transmission was killing me. And the intervention that's available is a drug called Nevirapine. This was state-of-the-art at the time. It is not state-of-the-art anymore. It is not what you should be on right now. If you're HIV positive, you should be on full treatment. But at the time, it was a single pill of Nevirapine that was being offered to the government for free by the manufacturers for a period of 5 years. It's a single pill a woman takes it when she goes into labor. It depresses the viral load, and it reduces the likelihood of the infant becoming infected to about 14%. And the government was refusing to roll it out. They put it out in sort of these 6 pilot sites in sort of wealthy areas, the city of Johannesburg, the city of Cape Town, ostensibly to do research on this issue, on whether they should be able to roll it out, what the implementation strategy would be, all of this sort of stuff. And they expressly forbade doctors in the public service who were available in other hospitals and who had acquired Nevirapine from making it available to women who were coming in to deliver when they were HIV positive. I will say this is in the background that there was no treatment available in the public health system in South Africa at the time. There was no treatment program at all, so if you were HIV positive, you were not going to get treatment unless you could buy it yourself. And the Constitutional Court came in on the first judgment that really hit at Section 27 of the Constitution to talk about the reasonableness of the plan. That the government's imposition of a policy that forbade doctors from making services available to pregnant women was unreasonable. And precisely because it didn't have budgetary restraint, this was an easy win. And it opened the door to the PMTCT program rolling out, followed a year later by the treatment program. But what I want to say about this case is it was built by the Treatment Action Campaign, which was a civil society organization put together of community members and communities of people living with HIV and those affected by HIV and their family members. And the limitation of this case, and the limitation of the power of these sorts of cases, is that it would not have mattered, I don't think, had we had this case if it were not built by a civil society movement. Because what happened after this case is it took years, months and years of continued litigation, of continued having community members go into facilities and identify specifically where drugs were not available and where services were not being made available to turn this into reality. It didn't happen just because a court ordered it. That takes civil society. The next case I want to talk about, and this is the only other case I'll talk about today, is this case of Mazibuko and others versus Johannesburg, the city of Johannesburg and others. And this doesn't have really anything to do with HIV, but it does go back to this issue of the power of courts and what's possible and what smart advocacy and good advocacy looks like when you're trying to intervene to make services available and realize the rights of access to health care. So in this case, Piri, which is a township that's part of Soweto, which is part of Johannesburg, sued over a new water plan. So Section 27, as I said, has the right of access to sufficient water. And the city of Johannesburg had looked at what was happening with water in the area. South Africa is a pretty dry country, and it was losing about 75% of the water through leaked pipes and through other things because the pipes had first been installed in Soweto and Piri in the 1940s and 1950s, and they had not been updated since. And so they were losing an enormous amount of water. And so the city came up with this update plan where they were going to put taps into everybody's house. And that really just looking at this metered connection issue of prepaid meters. They were going to make 6 kiloliters of water available per household per month. And then after that, you would have to go and put credit on your meter, and then you would get more water after that. And the challengers sued, saying 6 kiloliters was an insufficient amount of water to live a dignified life. The 6 kiloliters, by the way, was set by national policy. That was set by the National Water Department. And then there was this other issue that they challenged on, which was prepaid meters. In wealthier areas, they were putting in postpaid meters, which is like what we work on, which is basically credit meters, right? But the credit meters did not get this free 6 kiloliters of water, so there was this sort of compensation that was built into doing postpaid meters. But they didn't give a choice in this area. And the applicants won in the High Court, and they won in the Court of Appeal. They didn't win exactly what they wanted. They won at the Court of Appeal 42 liters per person per day, which was almost double. They were asking for 50 liters per person per day. to be rolled out. And they won that prepaid meters were considered unlawful, with that suspended for 2 years because they hadn't followed procedures to see if the city could remedy the problem. And what's interesting about this is it is the applicants who appealed to the Constitutional Court. And so the first lesson today is, if you ever go to law school and become a lawyer, don't appeal cases that you win. It is a bad idea. The second is, this was an ideologically driven issue. The prepaid meters was an ideologically driven problem that people saw. And then 50 liters per person per day was an ideologically driven issue about what is reasonable and what is reasonable. And they ultimately lost in the Constitutional Court, in a case that a lot of socioeconomic rights people feel was very poorly decided. I actually happen to think it was correctly decided. And the reason I think it was correctly decided is that context matters. Peary in particular was a relatively well-off area of South Africa in comparison to a lot of other areas. And had the Constitutional Court come in and said, 50 liters per person per day is the constitutional standard to put in place, that judgment would not mean anything outside of Peary. It wouldn't have meant anything in rural areas of Limpopo. It wouldn't have meant anything in rural areas of KwaZulu-Natal. It was not implementable. And I think it's very dangerous to think that we can solve problems the way these advocates, I think, tried to, by going to courts to solve problems that are much more complicated than just an order, right? And that's where I come back to, what does this have to do with HIV? I think that's where we are in the HIV movement today, right? We are no longer at this point where the problems are easy to identify. The problems are hard to identify, and they have to be driven by communities in terms of how we think about the response. And that goes to how we think about our role as advocates, our role as global health people, our role as what we do when we want to engage with policymakers. When I work with policymakers, particularly within amfAR, what's so interesting is how strongly they are trying to do the right things and make the right decisions in very difficult situations because they know their resources are limited and their control over the programs are very limited. And the hinge point that they're not able to get past is what happens as identifying what the failure points are. They're not able to identify, sitting in the offices that they occupy and sitting outside of clinics and sitting outside of communities, what the precise failing points are. And that, I think, is what our role as advocates are going forward. We have to replace what's broken. We have to replace what's broken in the system in which it is functioning, in the system in which they operate. So PEPFAR itself operates in a very clear, targeted approach, looking at how many people need access to treatment, how many people, we're going to budget X amount of dollars to put X number of new people on treatment, we're going to do whatever, right? And what happens with that, particularly when we look at things like key populations, is it leads to underinvestment in the community that is necessary because we don't know how many of them there are, right? We don't know how many men who have sex with men are in Dar es Salaam. We don't know how many men who have sex with men are in Nairobi. We don't know how many sex workers are in any of these places, right? Because the dynamics change at any given time, but we have to budget accordingly. And so what happens is, because somebody did a bad estimate years ago, we continue to rely on that estimate because we don't have something to replace it. And I think that is a point where we have to engage as civil society advocates and as global health advocates to figure out, how do you replace the broken piece of data that's holding everything up, right? And it can't just be saying the data are broken, because that doesn't work anymore. We have to design programs so that they work for people that are affected. And I want to bring the example of TB into this. TB has been functioning on the same model of intervention since the 1940s, really, since when drugs became available to treat tuberculosis. And it's this model called DOT, directly observed treatment. And what it requires is people who are diagnosed with TB to go out into the community, get diagnosed, and then come into the clinic every single day and have somebody watch them swallow their pills. We don't engage them in the way that we did with HIV. We don't engage them. The HIV movement has incredibly good adherence to treatment because we've done the hard work of making communities understand how treatment works, of doing treatment literacy, of having people become agents of their own healthcare. The TB movement has not done that. The TB movement has ended up in this position where they're overlooking and distrustful of their own patients. And we see the results of that. There are 2 million people every year dying of tuberculosis, of a disease that is curable, of a disease that is preventable, and largely a disease that is of health. And we could change that. That's a policy decision. It's a policy decision not to have invested in TB treatment. It's a policy decision not to have invested in a different method of operating in TB clinics. It's a policy decision to run TB programs, oftentimes with isolation wards, where if you don't come in for your treatment, we will actually send the police to go arrest you and put you into isolation and force you to take drugs without really doing the full spectrum of informed consent about what those are. And the TB drugs, for anybody who's ever been on TB drugs, I apologize, they're terrible. They have enormous side effects. If you get drug-resistant TB, the side effects of those are psychosis and permanent deafness, and you have to be on them for 2 years. And that is what we require people to take in order to not be a threat to the community. And I would like to state for the record, for drug-resistant tuberculosis, you're more likely to end up with psychosis than you are to end up treated, to end up cured. That's where we are with drugs for tuberculosis. We need community-led and integrated interventions that are based on treatment literacy and based on human rights, human dignity, and patient autonomy. Right? That's what we've done in the HIV movement. That is why we've had such success getting to 59% of people living with HIV on treatment. We have an enormous way to go, but it's different than where we have been elsewhere. And then the last point I really want to make is sort of what I've been talking about throughout all of this, which is health is local. It's not global. Global health is, there's an interaction between what happens at health, right? Infectious disease moves around on planes and on boats and everywhere. But the interactions of how we have to interact with health, of how we get communities healthy, of how we keep people in communities healthy, that happens locally. It doesn't happen from a top-down policy approach. We're not going to create a magical policy at a high level. And what that means is, if we want to do work in this space, it requires partnerships. It requires partnerships with the communities. It requires partnerships with the people who are affected around every health facility, so that we can have those civil society people feeding back to the policymakers about what's going on in their clinic. Because as much as we can go and yell about we need more people on treatment in this site and in that site and over there, the reason people aren't getting access to treatment is they feel excluded from the health system. Young people don't feel included in the health system, largely because, frankly, how many of us went to the health facility when we were 15 or 16 or 17, unless we actually had an urgent need to go? And we designed health systems to expect people to go there, proactively. But the intervention has changed. And I think that is where I'm going to leave it, so I'd be very happy to take questions. Thank you.
I'm actually going to come up here first before we do the questions and also present a welcome to you. So my name is Boris Lushniak. I'm the Dean of the School of Public Health. I know that Dean Ball was here to greet our speaker beforehand, and I'm here to basically say, wow. The reason I was running late was I was coming from a meeting of the Maryland Public Health Association in Baltimore, and it's fascinating because many of these issues are being discussed at that meeting. We talked about opioids, we talked about HIV, the many global health issues that exist, and I always define global health as the minute I open the doors of the School of Public Health. That's where the globe begins. To a large extent, though, that meeting was not as fruitful, I would say, as this last hour. Because the key feature of this partnership between BSOS and the School of Public Health and the co-sponsors of this lectureship is what? The key feature is interdisciplinary. Right? In Baltimore right now, it's us, the public health community, talking amongst ourselves. Yes, we have a few outside people there, but really, the answers to so many public health issues in the world in the 21st century is this interdisciplinary approach. Is what you, Brian, have brought to us today from your perspective, understanding policy, understanding global health, understanding HIV/AIDS in the world, and realizing that the common features, as you so eloquently had described, have been done, and they have proven not to solve the problem fully. Right? We thought at one time, okay, just give everybody condoms and let's teach them a little bit, right? A few pamphlets, a few things, it'll solve the problem. No. And at some point it says, oh, we have this wonder of pharmaceutical agents we can give. That'll solve the problem. No. And then we're still hoping for this sense of a vaccine someday, but that itself won't be the answer. So thank you on behalf of this partnership between Vsauce and School of Public Health for what you have brought to our school. The deans have been called to a special phone call soon, so we may have to walk out early, which is why I wanted to get in and thank you on behalf of the School of Public Health at the University of Maryland for being here. And now, whoever's moderating the questions, sir, you are back on. Thank you.
So we have some time for questions. I apologize, we don't have sort of a mic to go around, so if you can just sort of speak up a little bit, that would be really helpful. And stand, please.
So I think, one thing I have to give credit to, the question was, how can you advocate for these big top-down sort of organizations to really give credence to civil society and local voices, right? And I think, first I have to give good credit to PEPFAR in particular. The Global Fund has also sort of done this, though I'm a little less familiar with it. But PEPFAR has really made an active intention to reach out to communities much more under the leadership of Ambassador Burks. Civil society organizations have been brought into some of the planning meetings and some of that sort of stuff. But it's incomplete, and I think that's a key lesson. And I think the way that we do that, as people who may or may not have access to the room, that's those civil society organizations don't get access to the room, is we show up, first of all, with the people who should be in the room and present their voices. In South Africa last year, we brought the ambassador out to a treatment action campaign event where we released the People's Cop, which was a country operational plan that the treatment action campaign developed for PEPFAR, of what they wanted to see in PEPFAR's budget and planning. Right, so there are those sorts of things. And then there's the changing the dynamic. You show how civil society solves problems, right? Civil society has been solving problems for years for these programs. You show how they are doing that, and you can do it within the data. You can do it within the partnerships that you have about how, when we focused on this particular issue, and we told you what was going on in our community about the lack of healthcare workers, about the lack of training, about the lack of community support. And we put in some resources into documenting that. And we came to you and we showed it to you. It changed the way that the program was able to operate. I think that is key, is showing the value. And sometimes it's hard, and it takes years. It's taken years of collaboration and working with partners and developing skills and developing ideas about what those interventions should look like. But they are possible. And everybody wants to do a good job. I mean, let's be clear about that. Everybody who's involved in this fight is fighting it because they're trying, and sometimes they just need a little push into the direction of what's going to work better.
flipping the script and that people in the developing world had access to this top-of-the-line care, is there any possibility that that could trickle back into the developed world? Like, could people in the United States, is there any hope that they would have access to that kind of super drug?
So just to be clear, it's not a super drug. I mean, so TLD is a phenomenal drug in that it is this combination of the three drugs that you would really want to be on. There are equivalents that are available in the United States. There is a ViiV-specific equivalent that combines dolutegravir with lamivudine and abacavir. And then there's some Gilead versions that do tenofovir with a number of other Gilead products, right? So they're all single pill, once a day regimens that are available. And there may be equivalents. From the clinicians that I talk to, I am not a clinician, they suggest tenofovir, lamivudine, dolutegravir would be the thing that you would want to be on. That said, the policy decisions that we make in the United States are one to pay more for drugs. We have opted into a system in which we have decided to pay more for drugs. And that is the system. Like, fixing this for TLD is the tip of the iceberg, right? That's not really what we're going to fix. What we need to think about fixing is how we think about reimbursement for drugs in the United States. And that's a much different problem than just this TLD problem of it coming back into the country. No, I don't think that, the drug access issue in the United States is one of deciding who pays and how much, right? And we have big drug access problems in the United States because we don't cover a lot of the population. We've continued to put important programs in place like the Ryan White Act, Medicaid is there. Those are big payers for HIV, but they have gaps in them. And those are programs that need support in terms of how they cover drugs and support from policymakers to continue to fund. But I mean, as much as I think TLD being available internationally and sort of this weird problem of competition law and patents in the United States is an interesting story. I don't, changing that alone would not be the thing that would change the HIV epidemic in the United States.
As I recall in one of the maps with infection distribution, is there a way where the United States, Canada, China, and a few places in Europe have no data?
Oh, so those data are from UNAIDS. And UNAIDS does modeling of the epidemic in a whole lot of different countries. The only reason that those have no data is because UNAIDS does not monitor those particular countries. I mean, we have estimates on how many people are living with HIV in the United States. It's almost 1 million. It's just shy of 1 million people living with HIV, according to CDC estimates. So yeah, I mean, there are data on those. It's just UNAIDS does not capture those. Sorry, I should have clarified that.
Okay.
Anyone else?
So this meeting uses some similar different things that people are talking about different colleges. So can you talk a little bit about how you can operationalize that idea of civil society and what that might mean kind of on the ground in terms of those types of engagement? And then if you see, so the person I work with people who graduate with a photographer, and so if, thinking again through what some of those barriers might be in terms of what the perception of sort of civil society organizations versus people who are extremely marginalized who might not feel sort of part of what that might be envisioned as. Can you comment on that a little bit?
Yeah, I think, in the first part on how we operationalize the question of working with civil society organizations, what I would say, first of all, is that's not ours to operationalize, right? The communities have already developed civil society organizations. They are there. They are there to tap into. There are community organizations in any community that you go and work with. And you can find them, you can tap into them, you can find interested people to work with that will self-organize, right? Civil society is a self-organizing entity, and the moment you try and turn it into something that's not self-organizing, it becomes really problematic. Because then you get into weird competition about resources, you get into competitions about all sorts of things. But we do have a partnership that we're working on with AVAC, that's funded by the Gates Foundation, where we are partnering with a lot of civil society organizations that we've been working with for years in Zimbabwe, in Malawi, and in Tanzania, and trying to support the work that they want to do, and just providing additional resources, additional support for what objectives and goals and health priorities they see on the ground. So we're able to provide a lot of that support, and there is some funding available to them that's been very important. To this question of like, how do you deal with civil society organizations, particularly people who inject drugs, or MSM, or sex workers, I think it is incredibly challenging, and the dynamic matters, and where you are matters. In Tanzania, I've been on WhatsApp groups all day today, where MSM are being targeted in Tanzania with name campaigns. They're publishing names of people who are gay. It is a 30-year to life sentence to be gay in Tanzania. There are NGO registrations that are going out about controlling what money is coming into the country into different NGOs that are deeply problematic. And we need to work on those, and that's a policy issue to take up with governments, and that is sort of high level what happens in communities, and taking those lessons beyond sort of the national government about, you know, the pressure that can be exerted by international entities about what criminalization does. And what's interesting, you know, in Tanzania and in other countries, the stigmatization around some of these populations it's not centered in the ministries of health. It's not centered in the National AIDS Commissions. They understand the role that communities play. It's at a higher level than that. And that is a dynamic that you can play with. It is a dynamic that you can sometimes work with. If you can figure out who within governments are able to be worked with. And then coalition building. Big coalitions are harder to attack than small coalitions, right? Small coalitions that are single purpose and not general health organizations are much easier for government to attack. If they're just MSM groups, if they're just sex worker groups, they're easier to attack. And we have to look at the interrelationship between all of the communities and all of the work and do cross support. We can't do single purpose interventions anymore.
I just wanted to ask if you can relay my question about when you knew you wanted to do what you're doing now and how you got to that point.
So when I knew I was saying this earlier, I actually have a computer science background as well. I did a lot of work on open source software, and I originally went thinking about intellectual property when I went to law school and sort of issues of copyright in that front. And then sort of started to look around the world and go, access to medicines and patents are a much more important issue, right? And that's how I got involved. And then I worked in Brazil with an organization called Global Hiv, and between them, which was a local organization that did litigation on behalf of people brought in discrimination cases in Brazil, and then worked in South Africa with the Treatment Action Committee. Those are the entities that taught me everything that I know about this epidemic and how you deal with this epidemic. And I think, you know, being around, I came to this movement later than many, but being around the people who are genuinely working on this day to day from the ground level, those people are incredible. Like the friends that I've built there and the networks of people that they have and the dedication that you see. You know, my former boss wrote a piece a number of years ago where he talked about why poor people do work in this area. And they do it not because, you know, not the way big NGOs do this work, right? Big NGOs are a result of sort of an industrialization of the epidemic. And that is necessary and that is good, and it was essential to get the programs to where they are today. But when we leave, when we change jobs, when we go to other places, when NGOs change priorities, it doesn't mean the problem's resolved. For poor people, the problem remains, right? These are rights that affect whether people live and die every day. And I mean, that's the passion that I see.